And without further ado, luckily his bio was long. And let me introduce to you Dr. Eugene Shostak, AKA The Real Eugene Show. Welcome, Dr. Shostak, and thank you so much for being here.
Hi, thank you so much. Noah, can you hear me?
I can.
Great.
I can. Thank you so much.
Great.
So we got a lot to cover tonight. Ladies and gentlemen, let me just tell you this. This is going to be a great webinar, and I'm not looking to get your hopes up, but we had a talk the other day. I love this guy. He's young, he's smart, he's good looking. He does valves, and he's down to earth, and he's going to make this real simple tonight. So we're going to answer all the questions. We're going to talk about anatomy. We're going to talk about physiology. We're going to talk about who's a candidate, who's not a candidate, and why. And without further ado, Dr. Show.
Hi, thank you. Thank you, Noah, so much. I just want to make sure that the audio-visual stuff is working and you guys can hear me and see me.
You're good so far.
Okay, great, great. Let me see if I can. So I'm trying to share a screen. Are you able to see this?
Nope.
Okay, 1 second.
Let me see.
How about
Yep,
now?
here we go. Yep, perfect.
Okay, great, great. Let me see if I'm able to navigate this. I promise I do a better job with valves than I do with PowerPoint. Okay. All right. So good evening, everybody. Noah, thank you so much for having me here today. Before we do anything else, I just want to say that Noah is a great guy, and I am actually very, very impressed by the work that he does. I've known Noah for a few months now, and we've chatted before. But I think Noah is incredible, and he has really invested himself into helping patients with severe lung disease, and he has allowed us to have these webinars and be able to educate our patients and also educate ourselves, because we always learn from our patients by listening to our patients. So today we're going to talk about a relatively new technology, which is endobronchial lung volume reduction, or bronchoscopic treatment of COPD. I have a disclosure to make that I do speak for AstraZeneca. It's a pharmaceutical company. And more importantly, I don't have any disclosures that are relevant to this talk, which means that I'm not here because a company asked me to be here. I'm here really as a patient advocate to try to clarify some of the questions that folks may have, and hopefully at the end of this presentation we're going to open this up to questions. So I'm going to try to accomplish these tasks. We are going to talk about emphysema, just to remind everyone what is emphysema, and we will talk about this new technology with bronchoscopic lung volume reduction. We're going to talk a little bit about surgical lung volume reduction, because I think that that is something that you know is around, and you may hear about it. We're going to review a case. I'm going to show you a real case with some numbers, some data, and of course answer questions. So what is emphysema? If you think about a lung as a sponge, emphysema is a destruction of the lung, or destruction of those delicate air sacs where you now have holes, and because of this destruction, the lungs are not able to exchange gas, move oxygen and carbon dioxide across like they're supposed to. So that's really, you know, we think this is from, we know this is from related to cigarette smoking, but there's other causes of emphysema as well. Some are genetic, called alpha-1 antitrypsin deficiency. Now, you know, COPD, chronic obstructive pulmonary disease, has a number of symptoms. I think as patients with COPD, many of these symptoms will be familiar to you: chronic cough, being short of breath, producing a lot of mucus, having bronchitis and wheezing. So those are symptoms of COPD. But we now know that in addition to actual lung function, there's something else that's very important, and that is a mechanical problem, where because of the COPD and the difficulty of exhaling air, we think that there is too much air that's being trapped in the lungs, because the lungs aren't working well. This extra air accumulates in the lungs, and what it causes is hyperinflation, which is really too much air that's sitting in the lung that's not performing any useful function. But this air is pressing on the diaphragm, which is the main muscle of breathing. This air is causing pressure on the ribs, and it's causing the muscles of breathing to work extra hard. And the way I always explain this to patients and to their family members is, if you take a breath in, and now you start to breathe at that inflation, it becomes very uncomfortable. And this is what our patients with COPD experience. So the reason why this concept is very important is because this is where the valves come in. This is what the valves are trying to do, is they're trying to decrease this extra hyperinflation that's sitting in the lung. And this is a good diagram that sort of makes you think about a self-perpetuating spiral, where patients get short of breath because of the extra hyperinflation. They are then not being, then they're not active. They get deconditioned, and deconditioning causes more shortness of breath, and you really get into the spiral. And we're trying to break the spiral by reducing the hyperinflation, or allowing that extra air that's really non-functional to escape, and improving the activity. So all of you are familiar with pulmonary function tests, and this is really a way to get a sense of how well the lungs are functioning. The reason why I'm showing you this diagram is because there are different ways of performing pulmonary function tests. Your pulmonologist may ask you to sit in a glass box with a door. Okay, this is called a body box, or a plethysmography. That's the full name of it, but we call it body box. And there's other ways of obtaining lung function and obtaining lung volumes. And the reason why I'm pointing this out to you is because, for the purpose of discussing valves and determining who is the best candidate for the procedure, the pulmonary test should really be done in the body box, because that is the best way to determine these lung volumes. If the body box is not used, then the volumes may be smaller than they really are. And in the next couple of slides, I'm going to show you selection criteria. So because we need to be able to hit certain numbers, we need to be able to meet specific criteria to qualify for the procedure. So if you're not getting a pulmonary function test inside this body box, the degree of hyperinflation may be underestimated. So you have to be careful. And I can tell you right now that most private, smaller private offices do not carry a body box. This is usually found in hospitals or larger groups. So you do have to be careful and keep it in mind.
Excuse me, Dr. Shostak, before you go on, could I just ask you a quick question? So,
Please.
So every couple of days we hear about a new center that is doing valves, right?
Mm-hmm.
And when I spoke the other day, you mentioned that the residual volume can only be properly measured in the body box.
Correct.
Patient, if you're getting prepped for valves, but you've never had this body box, what would your move be? Like, how do you deal with that? Is that something you would want to go ahead with?
So in my practice, and I think in the majority of cases, I would hope that whoever is performing this evaluation for the valves is using the body box. Now, I know of certain institutions where a body box is not used, and we have had cases, or we have had patients who were turned down for the procedure on the basis of their residual volume not being high enough. When we repeated those numbers, those patients were clearly candidates. So it is, you have to remember, this is a new technology, this is a new procedure, and everybody's learning, including the doctors. So depending on how familiar or not familiar that a pulmonologist is with this specific procedure, I think as a patient, you really need to be very educated in some of these points. I do think that a body box is necessary, absolutely necessary. Now, a body box is less relevant when you're dealing with mild COPD, early stage COPD, because there's not that much air that's being trapped because the lungs are still working well. But once you start to getting into advanced stage and stage 3, stage 4, this is where the difference between using a body box and not using a body box becomes amplified.
Gotcha. So I've heard of cases where patients have actually been turned down and told they're not a candidate, but they never got the body box. So would you recommend that they try to go someplace and ask specifically for the body box?
Yes, 100%. There are other selection criteria. So certainly a body box is not the only determinant whether someone's a candidate, but absolutely. I think in order to do an accurate assessment, you need to be in a place that can do a body box.
Thank you.
I wanted to show everybody an example of what a pulmonary function test looks like, because again, I do think that patients sometimes will know more than physicians in this particular instance where we're dealing with a new technology that not everyone's familiar with. And the reason why I'm showing you this pulmonary function test is because I'd like to draw your attention to the circled numbers. Those are the ones that we look at. And so therefore, when you get a copy of your pulmonary function test, you should also look at those numbers and pay attention to them. Now, the FEV1, okay, is how much air you exhale in 1 second, all right? That is a measure of how well your lungs are functioning, your lungs are working. And it'll give you a percentage. An example here, this is 36%. Okay, and
I'm gonna turn Bluetooth on.
1 second. Let's just mute everybody for a second.
When we are preparing them, really arming.
Did we lose Dr. Shostak? Sorry, you're good. You're good, Doctor. Sorry about that.
okay, great. So I was just saying that FEV1 is how much air is exhaled in 1 second. In this example, this particular individual had 36% predicted, and that number went up to 43% after they gave albuterol. Okay, so keep those numbers in mind. So this is one of the numbers that we're going to look for when we select candidates for the procedure, FEV1. The next number that's important down here on the lung volumes is residual volume, RV. This is the hyperinflation that I was referring to. It gives us a sense of how much air is trapped in the lung. And in this case, it's 178% predicted. Okay, that is another number that we're going to look at for patient selection. So pay attention to these two numbers, FEV1 and residual volume. If the body box is not used, this residual volume is going to be lower. I can't tell you how much lower, but we've seen 50% lower or 25% lower. So this is where the box becomes important. Just to remind everyone that we have 4 classes of COPD, 4 grades: mild, moderate, and severe, and very severe. It is all based on the FEV1, that first number we looked at. So when we talk about the procedure, we're really focusing on class 3 and 4, which is severe and very severe COPD. If patients are in class 1 and 2, meaning that their FEV1 is more than 50%, they're not severe enough yet to be considered for the procedure. So that's important. Now, here is just a general summary of treatment, and all of you are familiar with different inhalers. Pulmonary rehab is definitely one of the treatments that appears fairly early on. And you know, we love pulmonary rehab. I think that there is a tremendous need for pulmonary rehab, and I think as you know, at least in my practice, my patients who have gone through a rehab program are you know, have all benefited. So it's sometimes a challenge to get a patient in because of logistics and travel and insurance, but everyone agrees 100% that pulmonary rehab is a great step here. Now, obviously, when patients are in a very severe category and they're having trouble just walking across the room, we are really at that point starting to think about valves. So I wanted to show you two pictures of what the valves look like. There are two companies that make them. I think the Pulmonx company, which makes the Zephyr valve, has really taken a lead in this technology. They have the most amount of data. If you look at the number of trials that were performed in the United States over the last 10 to 15 years, you know, by far the Pulmonx valve is the most studied valve. The Pulmonx valve, or the Zephyr valve, is on the left hand picture here. It's basically a little duckbill, and the duckbill will close when the patient takes a breath in, and it'll open when you exhale. So when you exhale, the air is going to come out of the lobe, of the part of the lung that's being treated with the valve. And when you inhale, that valve is going to close. It's not going to allow the air to go back in. So over time, that part of the lung is going to start to deflate, which is really what the volume reduction is all about. On the right-hand screen is the spiration valve. Okay, this is made by a different company called Olympus, also approved in the United States, has a slightly different design, and both are used for volume reduction. We'll talk a little bit more in the next slide. Again, this is a schematic of how a valve works. It allows the air to escape, but then it closes when the patient inhales, and it does not allow the air to go back in. So the big question that all of us have to answer, both as patients and as physicians, is who are the candidates for the valves? How do we figure out who is right for the procedure? So obviously this is for patients with severe emphysema. This is for patients who have symptoms despite being on inhalers, despite going through pulmonary rehab. FEV1, which is how much air you exhale in 1 second, has to be less than 45% predicted. Okay. Residual volume, by now we've talked a lot about residual volume in the body box. That number has to be greater than 150 and sometimes greater than 175% predicted. Depending on who you read, depending on the clinical trials, some trials said 150, some said 175. So there are some patients who have terrible emphysema, terrible lung function, but unfortunately they're not hyperinflated. And so if they're not hyperinflated, if their residual volume does not meet 150, they're not candidates for the procedure, provided they were checked properly. We also look for how much carbon dioxide there is in the blood. We do what's called a blood gas, arterial blood gas. It's taking some blood from the wrist, from the artery in the wrist, and checking how much carbon dioxide there is. You know, what happens with lungs that start to fail is that the carbon dioxide levels in the body start to rise. So we want to make sure that the levels aren't too high.
Now,
Now,
just a quick question before we go on. So
yep.
I just want to clarify, if I'm not mistaken, residual volume is the amount of air in the lungs that's not going to leave no matter how much you blow out, correct?
Correct. Correct.
So what you're saying is that the residual volume has to be at least 50% more than normal for a patient to be a candidate and to benefit.
It has to be greater than 150% predicted. So
Got it.
at least 1.5 times the upper limit of normal, at least 1.5 or 175% predicted.
Beautiful. Thank you.
Yep. So there is something we call fissures. I think that's extremely important to talk about fissures. Fissures are anatomical separations between the lobes. We have 3 lobes on the right and we have 2 lobes on the left. So if the lobes or the sections of the lung are separate from each other, we call it a complete fissure. If the fissure is incomplete, that means that there is touching, there is communication between 2 adjoining areas of the lung, okay? We do not, the fissures are something we're born with, okay? That's something that develops early in life, okay? So this is just your intrinsic anatomy. The reason why we talk about fissures at this point is because if you place a valve with the intention of shutting down a part of the lung that's not working, and you have an incomplete fissure, which means that there is cross communication, what's going to happen is that the air is going to come from the healthier part of the lung and it's going to cross into the area that you're trying to shut down. And that's going to negate your procedure. Your procedure will fail. Okay, so it is extremely important to measure these fissures, and we do them in different ways, which we will talk about in a few minutes. But I wanted to show you a slide that I just showed you before and add the fact that complete fissures based on the CAT scan is an absolute prerequisite for the procedure. So as far as what happens when a patient comes in or a patient is referred to us and we are evaluating them for the procedure. So the first thing that happens is that we need a CAT scan of the chest that is performed with thin slices. So those are 1.25 millimeter thin cuts, okay? The standard CAT scan that's done out in the community, ordered by a general pulmonologist, may not be 1.25 millimeters. It's usually about 2.5 millimeters, 3 millimeters. Those CAT scans are not high quality enough in order for us to analyze the fissure. So we will often redo the CAT scan with 1.25 cuts. We will do a pulmonary function test using a body box. You'll get an arterial blood gas to see how much carbon dioxide there is in your blood. We'll ask you to walk for 6 minutes, and we often do an echocardiogram. Oh my God, definitely fuck you. And often patients are asked to complete a pulmonary rehab program, or at least be involved in some type of a pulmonary rehab program. So I wanted to show you an anatomy scan. This picture that you see in front of you is a computerized report which is derived from the CAT scan that was 1.25 millimeters. So this is why we do 1.25 millimeter, is because we're going to then submit that information, that CAT scan information, to the company, and the company a few days later will send us this report. I want to go through this report because this report will give us an understanding of whether or not you're a candidate and where the valves could be placed. So the first thing that you see here is you see a picture of the right and left lung. Okay, that's the right, that's the left. The lobes have been assigned a specific color. For example, the right upper lobe is black, the middle lobe and the lower lobes are white, and the left upper lobe is gray, all right? Those colors correspond to how much emphysema you have in that lobe. The more emphysema you have, the darker the color. Okay, so white is no emphysema, black is a lot of emphysema, and then you got the shades of gray. The second piece of data that we get here is information about the fissure. So the fissure are the lines that separate the lobes. Okay, so you have one fissure on the left because you have two lobes, and you have two fissures on the right because you have three lobes. If the fissure is complete, it's a solid line. If the fissure is incomplete, it's a dotted line. Okay, so a dotted line means that that fissure is leaky. It's not going to, or rather, it will allow cross ventilation to occur. So, for example, in this case, even though the top of the right lung is destroyed with emphysema, you cannot put valves there because this fissure is not complete. The procedure will not work. We also, on the bottom here, know how much air is sitting in each section of the lung. And then our job as physicians is to look at this report and come up with where the target lobe is going to be. In this particular individual, the target lobe is the top of the left lung, left upper lobe, because it has a pretty, a reasonably good fissure, and it is also affected. It's not affected as much as the right side, but because of the fissure, because of the issues with the fissure, the left side is the target, left upper lobe. So this is the report that again is derived from the CAT scan. Now, when we look at all the data and we tell the patient that they are candidates for the procedure, what happens is that the patients come in on the assigned date, and they are given general anesthesia. So you are under full sedation. We perform a bronchoscopy. We go in with a small camera. So there's no surgery, there's no cutting, there's no scars. And we do a second test to check for to make sure that the fissures are truly complete. Okay, so before we place valves, we use what's called a Chartis system. A Chartis system is a device that's made by the Pulmonx company. And what it is that it's basically just a small balloon. We put the balloon into whichever area we think is going to be the target lobe, and we inflate the balloon, and there's a special mechanism, a special device that checks the fissure, that tells us how much air is flowing across the fissure. If the fissure is truly complete, there should be no flow when the balloon is inflated, right? If the balloon is deflated, you start to see the flow again. So this is a second way to know that the fissure is complete. It's almost like a safety check. There are some centers, okay, that do not use the Chartis system. My personal opinion is that Chartis is extremely important. It has been shown to add tremendous value to the patient selection process. An example would be somebody who has a good fissure based on a CAT scan, but when you do the Chartis, you realize the fissure is leaky, or vice versa. Someone whose fissure doesn't look great on a CAT scan, maybe it's a 50-50, and then when you go in and you do the Chartis, you realize the fissure is actually intact, and you can proceed with the valves. So this is another message that I wanted to convey to the audience, is that when you get evaluated in whichever center you're speaking with, make sure that they're using the Chartis, or ask them if they're using the Chartis. Okay, because not everyone uses this technology. But again, the worst thing you could do, in my mind, is place a bunch of valves and then not have the desired effect, right? Not be able to collapse the area of the lung that needs to be shut down. That would be probably the worst thing that you could do for patients. So we are very, at least in my program, in my institution, we're very careful about using the Chartis. Now, after the valves are placed, patient wakes up from anesthesia, they get a chest x-ray, and we do not send you home right away. We actually keep you in the hospital for several days, sometimes 3 to 5 days, because we want to observe how you feel after the procedure, and we want to make sure that there's no complications that happen, which we will discuss shortly. So, there's no free ride, right? Every medication, every procedure, every intervention has pros and cons, and there are complications that are associated with this technology. The most common complication, the most, I would say, number 1 and number 2 and number 3 on the list of complications is a pneumothorax. Pneumothorax means that air leaks out of the lung and can make you feel more short of breath. So the reason why this happens is because, let's go back to this picture. Let's imagine that we are putting valves into the left upper lobe, okay? So my intention is to shut down the left upper lobe, right? It's to basically deflate it and make it smaller. So when I make that left upper lobe smaller, what's going to happen to the lower lobe? I mean, your chest cavity, right, is still the same. So the lower lobe is going to stretch. It's going to expand in order to avoid any vacuum in the left chest. So as that lower lobe expands, especially if it expands too quickly, it can sometimes rip. You may have a small tear, especially since the lower lobe isn't entirely normal. Okay, so when that lung tears a little bit, air can leak out of that lung, and now we have a problem because that air is now going to start pushing the lung down and can cause a problem. It can cause more shortness of breath, more oxygen. So we want to make sure that a patient is in the hospital under our supervision if this were to happen. And we can promptly respond and put in a small catheter, a small chest tube to suck out that air, and then everything is fine at that point. If this complication, God forbid, happens when you're not in a hospital, when you're at home, there could be a big problem. And so luckily, this complication most often will happen right away if it's going to happen. Beyond day 4 and day 5, it's very unlikely for this to happen. So we feel good about sending you home. The frequency with which this happens is about 30%. Okay, so 1 out of 3 of you, if you were to get valves, may develop a pneumothorax. 1 out of 3. Now, again, it sounds somewhat concerning, but I think that number one, if you're in a hospital, that's a safe. If this happens while you're in a hospital, that's safe. And number two, even though we call it a complication, in reality, it's not really a complication, right? It is basically a sign, a reflection of the procedure working, because it means that the lobe, the treated lobe is closing very quickly, and therefore there's compensatory expansion of the nearby lobe. So usually we see this in patients who are going to have a good response. This is a copy of my hand. I took this picture yesterday, and it is a little sticker, or not a sticker, a little bracelet that we will give you before you go home. And this tells you, and it reminds you, and it also tells anyone else who's going to be taking care of you, that if you ever come into the emergency room with anything pulmonary related, chest pain, shortness of breath, doesn't matter. You have even if you cannot speak for yourself, you have a little sign on your wrist that tells the physician that they should get a chest X-ray, make sure there's no pneumothorax. And there's one for the right hand and there's one for the left hand. So we take the pneumothorax very seriously. Sometimes patients ask me, I live very far away. How am I going to have this procedure and then travel back home? Who's going to take care of me at home if there's a complication? My answer to that is that every single emergency room in this country is capable of getting a chest X-ray and placing a chest tube. Okay, so really this is as far in my experience, the most common complication if there's ever going to be a complication. So there should be no reason that you should feel that you have to be close to a major institution. Any emergency room can take care of a pneumothorax, and then we could and then the patient can always be transferred to a larger center if there's a need to. So what about outcomes? That is probably the most important patient-oriented question that there is. We are putting you through a lot. We're putting you through a procedure, valves. So when I talk to patients, I don't like using numbers, and I always try to sort of relate on a more personal level. And we talk about your activities of daily living. What are some of the things that you will experience? From clinical trials, we know that there is improvement in breathlessness. Patients have more energy. Patients are able to do more for themselves. As far as the oxygen goes, there's usually a reduction of 1 to 2 liters. So if you are on 2 liters of oxygen, you may come off of oxygen. If you're on 4 liters, you go down to 1 to 2 liters. Okay, again, this is not a miracle fix, but it does give you that extra edge that translates into improved quality of life. Okay, that is the most important end goal here. Now, there are some patients who come to me and they want, you know, real numbers. And so the answer to that question is on the screen: 17% improvement in FEV1, about a 1 liter reduction in the trapped volume of the lung, and about 40 improvement of about 40 meters in your 6-minute walk test. Just excuse me for a second. I'm going to turn the lights back on in the background. 1 second. So these are, you know, for those of you who would like to see raw numbers, this is what we see in clinical trials. I can also tell you that in my experience, I've seen, you know, numbers that are better than this. I've seen numbers that are similar to this. So, but again, I do believe that in the right candidate, quality of life improvements should be there after the procedure. And again, the right candidate is someone who has enough hyperinflation to warrant the procedure. So the higher the RV, the more bang for your buck you get, the more you have to, the more benefit you'll get from the procedure. And also the fissures. Fissures are extremely important because they really will determine whether valves will work or not. Now, I threw in a few slides on surgery because lung volume reduction surgery has been around for years. It's been around since early 2000s. Valves have only been around for about a year, okay? So it's worth knowing or at least hearing about volume reduction surgery. So the idea here is that a surgeon goes in and he cuts out the area of the lung that's destroyed, okay? It's sort of a simple concept. Not so simple in terms of outcomes. This slide, 1 second. This this slide here, the reason why I threw in this slide is to show you that there has been only one trial looking at lung volume reduction surgery, and that is it's a famous NET trial. It's in 2003. Okay, there have not been any more trials since 2003 until today. Look at how many trials there have been with valves. Okay, and this is only pulmonics. Remember, Olympus company also has their own trials, not as many, but the point here is that both physicians and patients are interested in non-surgical options here. So when we look at all these trials, they have really experimented with every possible permutation. The surgery trial only looked at patients who have upper lobe disease. So the tops of the lung are most affected. And they also have something called heterogeneous disease, which means that there are areas that are normal and there are areas that are diseased. And if you can cut out the areas that are diseased, you're going to feel well because the areas that are normal will take over. That's called heterogeneous disease. When all these different trials with valves were performed, they looked at patients who have disease in the lower lobes. So not just upper lobe, but also lower lobe. They looked at patients who have something called homogeneous emphysema. Homogeneous means that there's emphysema all over, all right? So that, yes, there are certain areas that are worse than others, but the difference between the bad lung and the good lung is very small. So the point here is that the approval that we currently have for valves, particularly the pulmonics valve, it applies to patients who have emphysema all over. It applies to patients who have emphysema on the top of the lung and the bottom of the lung, okay? So that is, I think, really a step forward in terms of applicability, how many patients this could be applied to. spiration valve from the Olympus company has also approval for the heterogeneous disease. They don't really have approval for the emphysema all over, according to the FDA. Um, uh, so that's something to keep in the back of your mind.
Gene, if you have if you have homogeneous disease where you have disease all over, would you be looking to put valves in multiple lobes or in all the lobes?
That's a great question. So whether you have emphysema all over or you have heterogeneous emphysema, which is just a one lobe that's most destroyed, the clinical, all of the clinical trials have really treated only one lobe. Okay, so the practice is to treat only one lobe, only one side. Now in Europe, valves have been around for longer, and so we are talking to our European colleagues about their experience in offering valves in both the right and the left lung, not simultaneously but sequentially. And that is a very hot topic right now that's being discussed in pulmonology circles. The short answer is we only do one lobe. Okay, probably in exceptional cases, on a case-by-case basis, it could, treating both sides could be considered in a sequential manner, but that is really not the norm. Interestingly enough, the surgical lung volume reduction trial was performed on both sides, so they would do both sides at the same time. But the valves are, as of now, the valves are just one side.
So if I could just ask this, is this, just let me know when you're done with this slide, and then I'm going to go to some questions if you don't mind. Sorry.
Absolutely, yeah. I think we're pretty much,
okay.
We're almost finished.
Okay.
This is just a kind of a side-by-side comparison of valves versus surgery. So obviously valves are much less invasive, no surgery, no scarring. They're not limited to upper lobe, okay? So it could be upper lobe, could be lower lobe, it doesn't really matter. We just go where the CAT scan tells us the emphysema is located. The pulmonic valves are approved for emphysema all over. The Olympus are not. You are required to have a complete fissure. It's a newer technology, and sometimes the valves may move, okay? So that is also an important point that I make to all of my patients. We cannot guarantee you that this is gonna be a one-stop shop, one bronchoscopy and you're done for the rest of your life. The reality is that valves are foreign bodies, they're little devices, right? So if there's movement, then we may lose some of the deflation. We may sometimes have to go back in. In clinical trial, this happened 20% of the time. Okay, 20% incidence of valve adjustment. So that is something you need to be comfortable with. Obviously surgery is a one-time shot. Lung's not going to grow back, but this is different. As far as surgery is concerned, it's obviously more invasive. Usually there are a lot of problems with air leaks, so patients stay in the hospital longer. We don't really care about fissures when we talk about surgery, and it is only approved for upper lobe disease. So if you remember, these are the numbers that we looked at earlier in the presentation. This is the numbers of an individual before a procedure was performed. This is a StratX report. So this is, now you guys are familiar with this. Based on this, we elected to treat the left upper lobe in this particular individual because of the emphysema destruction in the left upper lobe. Now notice that right upper lobe is also a target here. The fissures, the lines are black, which means that the fissures are 100% complete. So that's great. We elected to treat the left upper lobe. And these are some of the bronchoscopic pictures. So remember, even if the fissure is 100% complete, we always check it with the Chartis system, with the balloon. Sure enough, the fissure was good. We placed valves. In my practice, I have access to both valves, both the pulmonics and the spiration. And my philosophy is that the end, the most important thing is to make sure that we get a good result, a good procedural result for the patient. So we really decide during the procedure which valves we're going to use, how many we're going to place. This is not something we can tell you ahead of time. Sometimes patients ask me, which valves are you going to use, how many are you going to place? We have no idea until we get in, until we look with the camera. We have no idea. But the bottom line here is that, at least in my opinion, in my practice, having access to both valves allows me to provide sort of the best fit, if you will, for a particular patient. And I think the results speak for themselves. This is a chest X-ray. For those of you who are not too familiar with what a chest X-ray is, this is your right lung, this is the left lung, and this individual was treated in the left upper lobe. A few days later, you could see that, number one, the volume of the left lung is now half of what it used to be. And this little green line is showing you that the diaphragm, which is the main muscle of breathing, has started to rise. It started to come up. That is the whole point of volume reduction. That's what we're trying to achieve. We're trying to close off the upper lobe so that the lower lobe now starts to take over as the main working unit for the left lung, if you will. And the diaphragm went up by 9 centimeters. 9 centimeters is about 4 inches, 4.5 inches. So that is a tremendous volume reduction. So now that particular patient is breathing a lot more naturally. And you could also appreciate the right side versus the left side, that there's now a big discrepancy between them. So this is 2 months later. We repeated this individual's pulmonary function test. So this person went from being 43% to being 57% predicted. This person had a 145 cc or 16% improvement in lung function. The residual volume, if you remember on the previous slide, it was 3.2 liters, 175% predicted. It's now almost normal, only 112%. Okay, so this person lost 1.1 liter, 34% reduction in the volume. And also diffusing capacity went up. So needless to say, this person achieved a good result. This is in line with what the clinical trials reported. And this was, we have, I think a lot of you are familiar with Facebook and the Valve for Friends website, patient-oriented website, and you could read a lot of stories there that were successful. So that's just one of our success stories. The last slide here is about insurances, because this procedure is new. So it is it's sort of an evolving science, and insurance companies are starting to catch on to this. Medicare automatically pays for the procedure, no questions asked. There is now a number of private insurance payers that also will pay for the procedure. And thankfully, companies, the Pulmonx company and also the Olympus company are there to support physicians and help us with reimbursement, help us with insurances. So I know this sometimes becomes relevant, so I just wanted to put up a slide. Otherwise, this is all I have for you guys for today as far as slides. I hope that you found this educational. I hope this clarifies some of the misunderstandings and gives you a better idea of what this technology is all about. I'm looking forward to taking some questions.
Awesome. Thank you so much, Dr. Shostak. I have a couple of takeaways. So first of all, I noticed when you were talking about me before, you didn't mention that I was good looking, and I was wondering if there was a reason for that. But we could talk about that after. Between this presentation and our discussion the other day, the big takeaways for me that I didn't know about. Number one, the fact about the body box, okay? So if I'm a patient looking to go for this type of procedure and I'm screening, right? Because it's the hot thing right now. So everybody wants to go for this procedure. And what I've learned from you more than anything else is that not all centers are going to be equal, right? So my thinking is if I go for this evaluation and there's no body box test, that's a signal to me. That's an alarm to me.
Right.
high-res CAT scan. Okay, so everybody needs a high-resolution CAT scan. Chartis, very important to talk about fissures. And the other thing that I really liked most about what you said, because I was always wondering about this, but the idea that you bring both valves in, and you said you have a rep from each company in there with you, and that means that you have the ability to make the best decision for the patient on, it's really like boots on the ground based upon what you see once you get in. I always say if you're Thor, chances are you're going to use a hammer because it's the only tool you have. So in my, based on what we've talked about and what I've learned from you, as a patient advocate, I would recommend that you ask these questions when you go for evaluation. You say, okay, well, how come I didn't have a body box test? Or do you use both valves? Because I'm sure there's centers that only use one, right?
Right. Right.
Okay.
Absolutely. Absolutely. There are plenty of centers that just use one or the other. The Chartis device, which is a device that allows us to have that extra layer of knowledge when we perform the bronchoscopy before we actually place valves. That device needs to be acquired. That device needs to be purchased by the hospital. So not every hospital knows about this device. Some centers are not familiar, or some centers, particularly the ones that don't use the pulmonx valves, that you only use aspiration valves, they often aren't using the Chartis system because the aspiration didn't use the Chartis in their clinical trial. I think that I think that we have, even though it's still early in the clinical experience, it's been about a year, but we have definitely encountered cases where a Chartis made it was a deal breaker. We either did not perform the procedure when we thought we were going to do it, or we moved forward with the procedure when we were doubtful about it. And that's the other thing, is that when the patient goes in under anesthesia, I tell that patient that our intention is to place valves, but there is no 100% guarantee that I'm going to be able to do that. Okay, and it's different than let's say doing a biopsy. When you come in for a biopsy, 100% we're doing a biopsy unless there's something crazy happening. In this particular case, especially if the fissures are not 100% intact, if they're a little bit borderline, sometimes I tell the patient it's 50-50 on the fissure, and the Chartis is going to tell us whether we can do it or not.
I'm going to ask you a few questions from the chat, and then we'll go to the audience. So first question, if one is not a candidate for lung volume reduction surgery, does that also rule them out to be eligible for the valves?
No, absolutely not. So lung volume reduction surgery, first of all, besides meeting all the metrics in terms of the numbers, it requires a patient who can withstand surgery. Many patients are not able to withstand surgery, or they may not want to withstand surgery. So the idea here with this new technology is that we're trying to accomplish volume reduction medically without surgery, with the use of the valves. The converse question is also a good question. In other words, are there cases when you're not a candidate for the valve? Can you still be a candidate for the surgery? Now, I had one patient who was not a candidate for the valve because the fissures were completely leaky. So we can't put in valves. But that patient is a candidate for surgery, because when they do surgery, they don't care what the fissure looks like. They cut the emphysema out, and that patient actually had surgery and eventually did okay with predictable issues that result from surgery. So I think the surgery and the valves are really both complementary. We, of course, are sort of heavily looking at the valves because we really try to accomplish what the surgery wants to accomplish without doing the surgery. But I would, at least in my institution, both are on the table. And if the patient is not a candidate for valves on account of fissures, then we do talk to them about surgery. But that is not our first conversation.
Gotcha, gotcha. And if somebody is allergic to, like, is there any type of allergies that would prevent them from getting the valve?
Nickel allergy has been cited as a contraindication because both valves have nickel in them. Um, to my knowledge, we do not routinely test patients for nickel allergy. Okay, so if usually patients are late middle age, advanced age. By this time in your life, if you have never experienced nickel allergy, chances are you don't have it. But that is the one contraindication.
Gotcha. Now, for people who, there was a question about the sedation because somebody said that their doctor mentioned that, how much sedation do you use because they thought with their breathing difficulty, they might not be able to take it?
That's a very good question. The answer is that for this procedure, we want the patient to be under general anesthesia. The reason for that is because we need to go in and we need to do a lot of delicate work. We need to use the charters to make sure that the valve, that the fissure is not leaky. It requires a lot of precision. When we place actual valves, there's extreme precision that's required. If God forbid the patient starts coughing, then everything starts to go haywire. Now, as far as the safety of anesthesia in this patient population, so if you remember, there are certain things that we already would have checked. We already would have checked you for carbon dioxide retention by doing arterial blood gas. So we do not want to offer a procedure to someone whose carbon dioxide levels are high. That's a safety mark. That's really meant to keep you from having issues with general anesthesia. So you already have normal or near normal carbon dioxide. Diffusing capacity, which is one of the numbers that we didn't really talk about on the PFT, it's the bottom graph called diffusing capacity, DLCO. That number has to be more than 20%. Although that's sort of taken with a grain of salt. But the point is that we do our best to select patients that will be able to proceed safely. Now, a lot of this depends on the institution that performs the procedure. So this is not something that we spoke about before, but I am a strong believer that this technology should not be available to every single hospital in the country. You do not want this to be in every community hospital because, yes, you may have a great experienced proceduralist who can do a great job placing valves. This is not about a proceduralist. This is a team effort, right? The moment that I'm done with the procedure and the patient wakes up and comes out of the operating room or the procedure room, what happens to the patient? The patient meets many other members of our team, the PACU nurses, our mid-levels, our residents, fellows. All of these team members are taking care of you. So if you are, I could be the best proceduralist, but if I'm not surrounded by competent members of the team, then care is not going to be great. And so your ability to pull through the procedure is directly related to the competency and the comfort level of the anesthesiologist who's giving you anesthesia, obviously the proceduralist, and the hospital, their own comfort level. Now, there are many institutions that are great. In my own institution, we are actually used to taking care of sick people. As a tertiary referral center, we get calls from other places all the time, and we take on cases that were refused elsewhere. I'm talking about surgical cases. So our team is already used to taking care of people that were turned down elsewhere. And when a severe COPD patient comes in for valves, it's not that much different than things that we're already used to. So the pulmonologist may be correct that in whatever environment he or she is working, if you were to come into that hospital to have an operation and you needed anesthesia, many will feel uncomfortable about that. So I don't disagree with that. So you have to make sure that that particular hospital is comfortable taking care of sick people. And there are new centers that are sprouting every week. I hear there's this procedure is being offered in more and more centers, which is great. But one one thing that worries me a little bit is are we rolling this out in places that are not yet ready to take care of sick people? Okay, and that is a very important. As a patient, you have to research the institution, not just the person who's putting in the valves, because that institution is going to be taking care of you for the next 5 days.
I think that's great advice. You don't want to go, it's like when you're on the plane and there's a lot of turbulence. I look around and look at the flight attendants. You don't want to go to a hospital where they're nervous about taking care of you. They should be calm the whole time. Couple of other questions before we go to the audience. Can just a part of a lobe be deflated with the valves? So I guess maybe, is it segment by segment or full lobe by full lobe? How does that work?
One of the trials over the last 10 years looked at subsegmental. So only part of the segment gets, or only part of the lobe gets a valve. It does not work. The only way that you're going to accomplish a meaningful result is if you shut down the entire lobe. Okay, so sometimes patient asks me, how many valves are you going to put in? And my answer is as many as it takes to shut down the lobe. So no, subsegmental occlusions do not work.
Is there an upper age limit?
There really isn't. There really isn't. I mean, we obviously look at the whole patient and we look at all their other medical problems and comorbidities, but no, there is no specific cutoff.
What's the oldest patient you've put the valves in?
In the mid 70s. But that's not to say that if tomorrow I had someone in their mid 80s who were otherwise functional and were considered a good candidate, I would never say no just based on age.
So there's no actual upper age limit?
No.
Gotcha. Okay.
This is not like lung transplant. When you talk about lung transplant, age is one of the biggest initial cutoffs. 65 or 60 or 70. This is not lung transplant. So no, there's no age.
Okay, here's another question. I was told you cannot increase the O2 and decrease the CO2 to change blood gas results. Can you decrease the CO2 in the blood by using a BiPAP and pulmonary rehab? That's a little off topic, but yes?
I mean, so you can, I think I know what the individual is asking, a situation where the carbon dioxide levels are higher than we would like them to be to qualify for the procedure. And the question is there anything that I can do to bring down the carbon dioxide, to bring those carbon dioxide levels? BiPAP or nocturnal positive pressure ventilation sometimes could do that over time. It is not going to be a simple fix, because usually, unless there is some other competing cause, now there may be a metabolic cause, meaning that there may be a competing non-pulmonary cause of having high carbon dioxide levels, like kidney failure. So sometimes if the kidneys aren't working well, then the body starts to hold on to the carbon dioxide, starts to hold on to the bicarbonate. It's a substance that's excreted by the kidneys. If the bicarbonate levels start to rise in the blood, there's a compensatory increase in carbon dioxide levels. So there are people who have high carbon dioxide because their kidneys aren't working. This is not what we're talking about here. If we're talking about specifically high carbon dioxide because of respiratory failure, that's not something that can easily be ameliorated, because that's really a sign of underlying severe lung disease. Your physician can tell you if you have a mixed picture, and sometimes there are certain things that you can tweak for the kidneys to bring down the carbon dioxide a little bit. We can usually tell that based on the blood gas.
Awesome. So this is a question that I hear over and over again, and I'll segue into something else, but if you could just answer it and tell us why. The question is, does the valve procedure work for pulmonary fibrosis patients?
So the short answer is no, the valves are not approved for pulmonary fibrosis. They're approved for severe emphysema with hyperinflation.
Yeah, so guys, the big differential here is that, with obstructive disease, the problem is that there's too much air in the lungs, right? So we want to to deflate those lungs so that you get a better motion. This wouldn't serve any purpose because in pulmonary fibrosis, there's actually not enough air in the lungs. Now, let me ask you this. Bronchial stents, could you talk about, do you do those?
Absolutely.
Could you talk a little bit about that?
Yes, so I know exactly why you're asking that question, and that's a very good question, and I know that question has been asked before, recently actually. Bronchial stents and valves are two completely different devices. Valve is a one-way prosthesis, so to speak, one-way device that opens and closes in response to movement of air. A stent is a cylindrical or tubular device which is placed in the main airways, which means trachea, windpipe, right bronchus, left bronchus. And it is placed in situations when there is a blockage in those main airways. Main airways, the trachea and the bronchi, is not where COPD is not where COPD affects patients. COPD is at the periphery of the lung in the small airways, okay, at the level of the air sacs, the alveoli. The stents, when we place stents, we put them for central airway, okay, trachea and bronchi, and it could be used for patients with cancer if there's a blockage. There are certain benign conditions like tracheal stenosis, okay, and so when we talk about 3D printing and we're talking about engineering of stents, that is not for COPD at all. That's for central airway disease.
Could the stents in any way be of benefit to people with restrictive disease like pulmonary fibrosis?
Unfortunately not, because unfortunately restrictive diseases like interstitial lung disease and IPF are parenchymal conditions, parenchymal lung disease. So that's destruction of the actual tissue. That's, their bronchi are completely normal. So when I do a bronchoscopy, I go in with a camera and I look around, I see normal lung. There's nothing that is abnormal in the central airways in both of the patients, both COPD and pulmonary fibrosis. So unfortunately, no.
So even if they got the extra volume, it still wouldn't allow them to inflate the lung more.
Correct.
Do you have any thoughts on bronchoscopic thermal vapor ablation?
Not too many thoughts, but I'll tell you what I know. So it is one of the technologies that has been studied in Europe in very limited with a very limited clinical experience. Essentially, it involves installation of hot air vapor to sort of ablate the areas that are emphysematous. It is an irreversible procedure, which means that with valves I can put a valve and tomorrow I can remove the valve, okay, and I can completely reverse what I've done with the valve. There are certain procedures which we didn't discuss today. One of them is vapor ablation. One of them is coils. Some of you may have heard about coils, little nitinol rings that could be put in, and they sort of mechanically try to pull the lung down to cause volume reduction. Those are irreversible procedures. We can't take those out. Bottom line is vapor ablation is experimental, not approved by FDA. And as far as I know, there's no real studies that are actively looking at vapor ablation. It certainly is not going to be on the horizon in the next year or two.
Okay, here's a question. Had a body box before, but the door was not closed and no nose clip. And it wasn't me. That defeats the purpose, right?
Yeah, that doesn't sound right.
If the door is not closed, it's not a body box.
That's right. That's right.
Okay. Hesitant to do pulmonary rehab in a hospital due to cold and flu season. Does NOAA's boot camp qualify? That is to be determined. We're working with several hospitals now to see if we can make that a qualifier. But I agree with the fear. There's a lot of stuff going around right now. Dr. Shostak, is there any risk driving from 1,000 feet to 6,000 feet? So after the procedure, is there any risk with elevation and altitude?
So in general, there is no contraindication to air travel after the procedure. That being said, we treat this no different than we treat any type of lung surgery. If tomorrow you needed to have lung surgery for whatever reason, you would be told by your surgeon not to fly for at least several weeks. So I tell my patients the same thing. We obviously want to make sure that you get out of the immediate post-op period with no pneumothorax. We see you back a few weeks later, and we will wait for a few, I'd say, at least a month and a half or so to be safe. But in general, there's no reason not to fly with valves. Driving up altitude is similar to flying. So you could still enjoy air travel. I saw a patient of mine last week. She asked me this question. She has valves on one side. She has obviously emphysema on the other side. You have to also understand that by the virtue of having emphysema, whether you have valves or you don't have valves, you are at a high risk of developing an issue, a pneumothorax. But that risk, I don't think, is higher by having valves than not having valves.
I'm waiting for the final approval for spiration. My doctor said I will only stay in the hospital for 1 day. Does that sound right?
Absolutely not.
Okay, there you have it. Is there an FEV1? We're going to speed round now. Is there an FEV1 that is too low?
So 15% is the low, is the cutoff that we use, 15%. Now, I will also preface this by saying that everything that we know about this technology is based on clinical trials, okay? So in clinical trials, 15 was the cutoff. Does that mean that if you have 14, you are not going to benefit and you should be disqualified automatically? Of course not. As the more experience we gain as physicians and as centers, the more comfortable we're going to become with some of the outliers. My very first patient was, I think, right on the cusp of 14 or 15. And yeah, I'd like him to be higher as my first patient, but he had good response. He went up to maybe 29, 30 from 15. I mean, it's a modest response, but so the answer is that you really need to look at the full picture. And this brings up a very good point, because this is not a clear-cut science, right? If this was a clinical trial, then this becomes very simple. If you're 14, you're out, and if you're 15, you're in, and there's just no, it's very binary. Either you're in or you're out, and it's going to be the same across every center. Now we're no longer in clinical trial; we're in clinical practice. Okay, you will have some centers that may refuse you, and others that may not refuse you. And as a patient, this can be very confusing. How come one center said no and the other center said yes? And the reason is that sometimes when things fall outside what is known to be safe based on clinical trials, it becomes at a physician discretion. So if you are, as a patient, if you are being evaluated and you're told no, if you're being told no because your fissures are leaky, that's not something that a different center is gonna tell you otherwise. But if you're being told no because you missed a cutoff here and there a little bit, but otherwise you are considered to be a good candidate, I would actually go for a second opinion.
So if mom says no, ask dad.
That's correct.
Okay, so I appreciate this valid info and patient-centered care you provide. Besides the size and the fit, is there a major difference in the valves, for example, in longevity, failure, or complication rate?
It's a very good question. I'm not aware of at least based on what we know, which is a limited amount of data in the United States. I'm not aware of a whole lot of differences in terms of either complications or procedure success as far as comparing the two valves goes. We do know that both valves were used in clinical trials and both have FDA approval. So they both were able to demonstrate what is necessary to demonstrate to get through the FDA. For those who are interested in clinical trials, you should know that the Pulmonx trial looked at 12 months follow-up data. The Olympus, which is the spiration valve, was a 6 months follow-up data. Okay, so those are the published results. They both were successful, similar results. Now, what's going to happen 5 years down the road to those patients who we're treating today? with spiration or with Zephyr, that's to be determined.
Don't worry, only 36 more questions. I was told my emphysema was evenly spread across all lobes, and this is why I was not a candidate for lung volume reduction. Does this eliminate me from valves?
So the answer is it does not, and that is exactly one of the differences between volume reduction surgery and the valves. The reason why you're not a candidate for surgery is because clinical trials only looked at heterogeneous emphysema. Homogeneous emphysema has an approval for the Zephyr valve only. Now, some people may put in an Olympus valve, aspiration valve in homogeneous. That's a provider thing. But if you look at it based on what is FDA approved, it is for homogeneous emphysema has an approval for the Zephyr valves. And we have treated patients with homogeneous emphysema.
What are the valves made of?
They are nitinol valves with I believe some silicone covering. It's if you're sort of interested in more, if you just go on their website, they have some specifications.
Okay, this is an interesting question. If both upper lobes, both sides have the most damage, but the right is worse, but the fissure is not complete, but the left side fissure is okay, do you do right or left?
So that is exactly what one of the pictures I showed you was exactly that case where the left was less severely destroyed, but the fissure looked better. It's all about the fissures. So you may interrogate, you may check both fissures during the procedure. You can do that, and maybe the right fissure will be intact if you're lucky. But if that right fissure is not intact, you cannot do the right side. It doesn't matter how destroyed one is.
The fissure is not intact, you must go back.
You must pick the side that has the fissure.
Okay. Can the procedure be performed without general anesthesia?
I'm not aware of anyone who would do that.
Or who would want it done? Do nodules affect selection?
Very good question. Nodules may affect selection. You need to prove that the nodules are stable. Okay, so sometimes if a nodule pops up, I have a patient last year, she did not have a nodule. This year, she has a new nodule, 8 millimeters. We are evaluating her for the valves. It doesn't matter if this nodule is in the target lobe or not in the target lobe. We need to delay things and make sure that nodule is stable.
Does NTM or MAC disqualify you?
So there are many people who are colonized with MAC. And so it depends. If there is active symptoms of MAC and there is tons of bronchiectasis, yes. If you are simply colonized by MAC and you have minimal bronchiectasis, which is destruction of the lung from MAC, then no. In some cases, I have done a bronchoscopy, just a simple bronchoscopy with a quick wash, just to get a sense of what lives in the lung and make sure to treat things as much as possible. But in general, if we go in and we see a lot of thick mucus, then no, I wouldn't put valves.
Gotcha. What happens to the lobe of the treated lung? Does it collapse? And I think you said ideally yes, right?
Ideally.
That's the goal.
That's the goal.
All right. My pulmonologist said they do endobronchial valves, but not Zephyr valves. So what is he talking about? So he's talking about the spiration.
Correct.
My pulmonologist said he does them, but only in his garage on the weekends. Is that a problem?
It depends on what you're trying to achieve.
Okay, that's a good point. Does having approximately how many patients have you performed this procedure on?
We have done 6 or 7 so far. We have we have screened or evaluated, I would say, probably over 40. We have. If you ask me this question in the next 2 or 3 months, that number is probably going to be double, because as we are growing as a program and getting more and more information out there, the referrings are coming in now more and more. So we have quite a few in our pipeline. I think a lot of this is a reflection of how applicable is this technology to patients. This is not an inhaler, right? This is not something you're gonna do left and right. So we have always, at least in the beginning, we've taken and our philosophy is to really cherry pick the patients to make sure we have good results. So could I have done more? Probably. There were definitely patients who were marginal as far as whether they'll benefit or not. But we chose to not offer procedure yet to those patients and make sure that we have good results.
And as the technology is more understood and you gain confidence, I mean, probably the scope of patients will widen.
100%, 100%.
Is there increased danger of blood clots?
No.
Okay, I have a collapsed middle lobe. Will that affect my hyperinflation rate and or disqualify me for the valves?
It'd be interesting to find out what the reason is for collapsed middle lobe to begin with. If it's hard. I mean, if it's collapse for, due to just chronic middle lobe collapse, then provided that that lobe is not filled with chronic mucus, technically no. Technically, it shouldn't disqualify you as long as you have other targets. But we would have to be very careful. I think someone like that should have a bronchoscopy beforehand to evaluate the middle lobe and make sure that there's no chronic some bacterial infection sitting there that's going to create problems.
Yeah, that's a tricky one. Last question from the chat. Can you still be on the lung transplant list if you've had the valve?
So the answer is yes. And I have recently encountered a difference in opinion from facilities that perform lung transplant. As far as this particular question goes, majority of lung transplant centers, when I talk to the physicians there, the pulmonologists there, they say that absolutely, a valve is a bridge to make you feel better until you can get the lungs whenever that day comes. Some centers shy away from valves. My general thought on this is that I don't see a reason not to have valves even if you're actively listed. Because even if you develop certain complications, such as a pneumothorax, those can be treated easily. They really should not disqualify you from a transplant. But I think this is also a topic that is still sort of being discussed in the transplant circles.
Sure. And before Donnie sings us out, thank you so much, Dr.
Yes, thank you. Thank you.
Bye-bye.
Bravo. Thank you.
Thank
you.
you. This way.
Thank you.